مؤنس أكاديمي. بسم الله الرحمن الرحيم. أقدم هذا العمل خالص لوجه الله الكريم، آمل أن يكون عونا لشباب الأطباء ليقدموا خدمة صحية عالية المستوى ترقى بالطبيب العربي وتخدم المجتمع بأمانة وإخلاص. From bedside to best practice. Here we have a 57 years old diabetic woman with history of cholecystectomy, gastroesophageal reflux disease on chronic BPI, hypertensive, presented with chronic diarrhea. Her bowel changes started 6 years ago. About 1 year earlier, after her cholecystectomy, he feels that the frequency of diarrhea is worsened and recently has an urgency. He has had 2 episodes of incontinence in the last 2 months. He denies seeing any blood in her stool or having any nocturnal symptoms. Also, she denies fever, weight loss, or fatigue. He feels that her life is being changed over the diarrhea because whatever she goes, she needs to identify where is the bathroom in the event because she have an urgency, and when she feels that you need to defecate, you have to go urgent to the bathroom. Her medication is pantoprazole, lisinopril, and metformin. Her last colonoscopy was 5 years ago. Show no polyps with Boston bowel. Preparation is excellent. You perform an routine workup and serological assessment which reveal is unremarkable. So you make a C. diff study as well as infection etiology which is negative. You advise to make a colonoscopy and take random biopsy, and here is a figure of a colonic mucosa which reveal normal mucosa. No ulceration or edema or hyperemia. You take a biopsy from the terminal ileum, right and left colon, and the pathology come back saying that there is 33 lymphocyte per 100 surface epithelial cell with preservation of the crypt. So it is 33% of lymphocyte infiltrating the epithelial with preservation of the crypt. What is the best management for this patient? You will start giving her abysmal subsalicylates or budesonide or metformin, or stopping metformin and pantoprazole, or give a course of 5-aminosalicylic acid. To answer this question, you have to know the diagnosis. Here is the diagnosis coming from 2 things. The colonoscopy with normal mucosa and biopsy show 33 lymphocyte in surface epithelium. So it is lymphocytic colitis. So it is microscopic colitis. There is 2 types of microscopic colitis: lymphocytic colitis or collagenous colitis. Collagenous colitis, thick band of collagen type 2 in the submucosal space. So it is a lymphocytic colitis. To treat the lymphocytic colitis, we have AGA guidelines for diagnosis and management of lymphocytic colitis. AGA recommended 3 potential initial therapies. Either start budesonide, bismuth salicylates, or 5-aminosalicylic acid. Whatever you want you can start it. والثلاثة موجودين. طيب نختار ايه؟ 2017 الامريكان جورنال of Gastroenterology Clinic and Systemic Review recommend treatment according to the severity. If it is mild, so you start Imodium, loperamide. If it is moderate, start with bismuth subsalicylates. If it is severe, budesonide 9 mg per kilogram for 8 weeks. If no respond, biological therapy. But the point here, please, before you initiate treatment, you have to look what is the cause of lymphocytic colitis. Smoking, PPI, serotonin selective uptake inhibitors, all these some of the causes of the lymphocytic colitis. And this patient taking PPI because he have a chronic GERD. So you should first review the medication, and from the medication you found PPI is present. So the recommendation is stop PPI and wait to see if the patient respond or not. If the patient does not respond, you have to choose from, according to the Journal of American or American Gastrointestinal Association, to start with bismuth or 5-aminosalicylic acid or budesonide according to the severity. So the point, please check the drug list before you initiating therapy. So the treatment will be stop pantoprazole. Here's a second case of 56 years old woman with history of chronic obstructive airway disease, presented to the emergency room with an onset of abdominal pain 24 hours earlier. He reports that these pain were 6/10 and cramping and diffused through over her abdomen. On admission, the patient serological assessment was unremarkable, except white blood cells is 16, and about 6 hours after the onset of the pain, patient experienced multiple episodes of bleeding per rectum. He described 6 bowel movements with blood and clot mixed with stool. CT show moderate segmental colitis involving of the descending colon. The patient was admitted, but her diarrhea continued over subsequent 24 hours with less blood than previous, but the same frequency. So give her persistent symptoms. So you decide to perform an endoscopy, and endoscopy you found a longitudinal ulcer in the splenic flexure. So, and in the descending and maximum in splenic flexure, and nothing in the transverse or the right colon. According to the ACG guidelines of the disease state, what you are going to recommend to treatment this patient in addition to intravenous fluids? You admit the patient and make bowel rest, or adding ciprofloxacin metronidazole, or adding after ciprofloxacin metronidazole CT angio, or CT angio and refer to ICU, or you consult the surgeon. What you are going to do, you have to diagnose first. It is a case of ischemic colitis. Why ischemic colitis? Because the ischemic colitis is longitudinal ulcer with ulceration till the splenic flexure. Water-shaded picture. To treat, you have to identify the severity. The severity can be identified by two things. First, you have to have chronic ischemia plus more than at least three of the following risk. Is a male patient, hypotension, tachycardia, abdominal pain without rectal bleeding, or hemoglobin less than 12, white blood cells 16, blood urea nitrogen more than 20, lactose dehydrogenase more than 350, sodium less than 135, and or mucosal ulceration of the colon. So this patient is have chronic ischemia and white blood cells is 16, and there is mucosal ulceration. That's meaning we have two white blood cells and mucosal ulceration. So 2 plus chronic ischemia, it's moderate. If more than 3, it'll be severe. Is chronic ischemia and only 1, is mild. So this patient meets the criteria of 2, which meaning it is a moderate disease. So the treatment of the moderate disease is intravenous fluid, bowel rest, antimicrobial treatment. CT angio only indicated if isolated right colon ischemia. Surgery and ICU admission only indicated in if more than 3 risk factors, means severe, if peritoneal signs on physical examination, which is rebound tenderness, if you found a gangrenous area by colonoscopy, or if it is isolated right colon ischemia, or if you found in the CT portal vein gases or pneumonitis linearis. And here is the picture of portal vein gases, and longitudinal line was called pneumonitis linearis, which meaning that air in the submucosa. So the treatment, the recommendation is bowel rest, intravenous fluid, metronidazole. if في النهاية بشكركم، وإذا كان هذا المحتوى يلقى إعجابكم يا ريت ندوس لايك وشير، وأقبل أي اقتراحات ممكن تتعمل، وإن شاء الله في حلقات جاية لحد ما نغطي كل GIT and liver.